Welcome back to the show. I'm Mark, and today we are tackling a condition often referred to as the silent killer in vascular medicine, the abdominal aortic aneurysm, or AAA.
And I'm Dr. Sarah. Today's episode title is a bit of a provocation. Do more complexity give more predictions? For decades, we've relied on one simple number, the maximum diameter of the aorta, to decide when to operate. But as technology evolves, we're asking, is that simple number enough? Or does the complexity of the patient's anatomy hold the real secret to predicting a rupture?
It's a massive topic. We're going to look at why these aneurysms form, why they are so hard to predict, and whether the high-tech computational models we're seeing today are actually better than a surgeon with a ruler.
Before we get into the complexity part, let's ground everyone in the basics. An abdominal aortic aneurysm is defined as a permanent localized dilation of the abdominal aorta with a diameter of at least 3.0 centimeters, or more than 50% larger than the normal arterial diameter.
And most of these are infrarenal, right? Just below the kidneys?
Exactly. About 90% are infrarenal. The reason this is a silent killer is that most patients are completely asymptomatic until the moment of rupture. And once it ruptures, the mortality rate is staggering, anywhere from 65% to 80% if they don't reach the OR in time.
That's why screening is so vital. But the big question we're answering today is, once we find one, how do we know if it's going to pop? Sarah, let's talk about the why. Why the aorta, and why specifically the abdominal section?
To understand the complexity of the prediction, you have to understand the complexity of the wall. The aorta isn't just a pipe, it's a living, dynamic organ. It has three layers: the intima, the media, and the adventitia.
I've heard the term vasa vasorum come up in these discussions. How does that play into the infrarenal location?
That's a key clinical pearl. The vasa vasorum are the tiny blood vessels that nourish the walls of large arteries. Interestingly, the infrarenal abdominal aorta has significantly fewer vasa vasorum compared to the thoracic aorta. This makes the lower aorta more dependent on diffusion for nutrients and more susceptible to metabolic stress and injury.
So you have a wall that's getting thinner and weaker, and then you add the hemodynamics. We aren't talking about a smooth flow, we're talking about turbulence.
Right. As the bulge grows, the blood flow becomes turbulent. This creates wall shear stress. This mechanical stress actually signals the cells in the wall to undergo more inflammation. It's a vicious cycle. The bulge causes stress, the stress causes weakening, and the weakening makes the bulge bigger.
Before we get into the complex AI stuff, let's talk about the standard risk factors. If I'm looking at a patient chart, what are the red flags?
Smoking is the king of risk factors for AAA. It's not just a minor association. Smokers are 7 times more likely to develop a AAA than non-smokers. And interestingly, it's a stronger risk factor for AAA than it is for coronary artery disease.
What about gender? We always see this in older men.
Yes, it's much more common in men, about 4 to 6 times more likely. However, here is where the complexity starts to matter. While women get AAAs less often, their risk of rupture at a smaller diameter is significantly higher.
That's a huge point. If we just use the simple 5.5 centimeter rule for everyone, we might be missing women who are in danger at 4.5 centimeters.
Exactly. Other factors include age, rarely seen before 50, family history, and hypertension. But surprisingly, diabetes actually seems to be protective against AAA growth.
Wait, diabetes is protective? That feels counterintuitive.
It is. We think it's because the glycation of the collagen in the aortic wall, the extra sugar, basically, stiffens the wall and makes it more resistant to being eaten away by enzymes. It's one of the few times having diabetes might actually help a vascular structure stay intact.
This brings us to the heart of our episode. Currently, the gold standard is the maximum diameter rule. If it's 5.5 centimeters in a man or 5 centimeters in a woman, we consider surgery. Sarah, why are we questioning this? It seems simple and effective.
It's effective for a population, but it's often wrong for the individual. We've all seen 7-centimeter aneurysms that stay stable for years, and 4.5-centimeter aneurysms that rupture unexpectedly. Diameter is a 1D measurement of a 3D problem.
So when we talk about complexity and predictions, what are we actually looking at?
We're looking at biomechanical mapping, specifically peak wall stress. Imagine a balloon. If you blow it up, the diameter tells you how big it is, but if one part of the balloon's wall is thinner or has a weak spot, that's where it will pop, regardless of the total size. We use finite element analysis, the same math engineers use to test bridge stability, to calculate where the stress is highest on a specific patient's aorta.
So you take a CT scan, feed it into a computer, and it tells you the breaking point of that specific patient's tissue?
That's the goal. We also look at aortic tortuosity, how twisted the vessel is, and the presence of intraluminal thrombus.
I wanted to ask about the thrombus. You'd think a thick layer of clotted blood inside the aneurysm would act like a cushion and protect the wall. Is that true?
It's a double-edged sword. While it might reduce the pressure hitting the wall directly, it also creates a localized area of hypoxia, low oxygen, and inflammation. The wall underneath the thrombus is often much weaker and thinner than the rest of the aorta. So a complex prediction model accounts for the thickness and position of that clot, whereas the simple diameter rule just measures the whole thing.
We can't talk about complexity without talking about artificial intelligence. How is AI changing the game for AAA?
AI is helping us with growth rate prediction. Instead of just looking at where the aneurysm is now, machine learning algorithms analyze thousands of previous cases to predict how fast this specific aneurysm will grow in the next 12 months.
That would be a game changer for watchful waiting.
Exactly. It moves us from reactive medicine to predictive medicine. We're also seeing radiomics, where the AI looks at pixel-level data in a CT scan that the human eye can't perceive. It looks at the texture of the aortic wall and the surrounding fat, peri-aortic fat, to see if there are microscopic signs of inflammation.
So, to answer the title of our podcast, does more complexity give more predictions?
The answer is a cautious yes. More complexity gives better predictions, but it also creates more noise. We have to be careful not to overdiagnose or perform unnecessary surgeries because a computer model said the stress was high, even if the patient is clinically stable.
As we wrap up, let's talk management. If a patient is in that complex danger zone, what are the options?
We have two main paths: the classic open repair, where we literally replace the section with a synthetic graft, and EVAR, endovascular aneurysm repair, where we go through the groin and place a stent graft.
EVAR has become so popular because it's less invasive, but it comes with its own complexities, like end leaks.
Exactly. And that's why the prediction doesn't stop after surgery. We have to monitor these patients for life to ensure the complexity of the repair doesn't fail.
This has been a fascinating look at how we're moving away from a one-size-fits-all ruler approach for our patients to a digital twin approach.
The take-home message for our listeners: diameter is the starting point, but the shape, the stress, and the biology of the patient is where the future of vascular surgery lies. If you have a patient with an AAA, don't just look at the 5.5 centimeter mark, look at the whole picture.
Thanks for joining us for this deep dive. We'll see you in the next episode.
Stay curious and keep scanning.